Hi, I'm Beth Badalino, CEO of Healthy Women, and I want to thank you for joining today's webinar on the global threat of antimicrobial resistance, or better known as AMR, and its impact on women. Each year, more than 2.8 million antibiotic resistance infections occur in the United States alone, and more than 35,000 people die as a result of AMR. The Infectious Disease Society of America considers antibiotic resistance a public crisis. The CDC calls AMR one of the biggest public health challenges of our time, and the World Health Organization declares AMR as one of the top 10 global public health threats facing humanity. The COVID-19 pandemic has presented new AMR challenges, as many patients exhibiting COVID-19 symptoms receive antibiotics to reduce the chances of getting a bacterial infection. The pandemic has also directed attention, energy, and resources away from the issue. That's why conversations like we are having today are so critical. At Healthy Women, we want to empower women with the information that they need to keep themselves and their families healthy and safe. We also want them to know what they can do in the fight against superbugs. We have assembled an esteemed panel of experts who will delve into the urgent topic. But first, I would like to welcome today's moderator, Thomas Heyman. Thomas served as president and CEO of the Sepsis Alliance since 2013, driving to increase sepsis awareness. The Sepsis Alliance serves more than 2.5 million patients, family members, caregivers, and medical professionals each year. Thank you so much for joining us, Tom. And now I will turn it over to you.
Thank you for the introduction, Beth. I'm very happy to be here and delighted to moderate today's webinar, The Global Threat of AMR and Why Women Need to Know About It. Thank you for joining us for what I know will be an informative and engaging conversation on this very important topic. It's now my honor to introduce today's esteemed panel. Dr. Helen Boucher is an attending physician and faculty at the Tufts Center for Integrated Management of Antimicrobial Resistance and the Dean ad interim and Professor of Medicine at Tufts University School of Medicine. Dr. Boucher is internationally known for research on infections in immunocompromised patients and infections by S. aureus, one of the most dangerous of the staph bacteria, for which she has investigated new anti-infective agents. As director of Tufts Medical Center's Heart, Transplant, and Ventricular Assist Device Infectious Disease Program, Dr. Boucher has seen the dangers that uncontrolled infections pose for vulnerable patients. Her research focus became an institutional mission in 2018 when she became a founding director of Levi CMAR, a cross-disciplinary initiative between the university and the medical center aimed at combating antimicrobial resistance through research, education, and policy. Next, we have Dr. Sandy Kao. Dr. Kao is the Vice President of Clinical Performance and Transformation at the New Jersey Hospital Association, where she assumes leadership over the Health Research Education Trust of New Jersey. The trust includes initiatives related to perinatal quality, hospital quality improvement, opioid prevention, HIV prevention, and implicit bias training. Dr. Kao serves as an executive leader on clinical quality, patient safety, workforce, clinical education, research, industry licensure, regulatory and professional matters involved in the delivery of high-quality care by NJHA member organizations. Dr. Kao is an experienced family nurse practitioner and educator with a demonstrated history of working in the academic, hospital, and healthcare industry. Dr. Kao is also a member of the Sepsis Alliance Advisory Board. Thank you, Sandy. Next up is Amanda Jezek, Senior Vice President for Public Policy and Government Relations at the Infectious Diseases Society of America, IDSA. Since 2011, Ms. Jezek has led the policy development and advocacy for a medical society of over 10,000 physicians and scientists, with a focus on antimicrobial resistance, incentives for antibiotic and diagnostics R&D, immunizations, biomedical research, public health, and physician workforce issues. She develops and implements strategies to advance the Society's policy goals and serves as the Society's lead representative with Congress federal agencies, and other policy stakeholders, and as the Society's lead media spokesperson on policy matters. Professor Kevin Alderson is the director of the Social Innovation on Drug Resistance program at Boston University. He also teaches health law and corporate law, where he's the N. Neil Pike Scholar in Health and Disability Law and co-directs the Health Law program. In addition, he is executive director of CARBEX, a global partnership hosted at BU Law that's focused on supporting developers of promising new antibiotics, diagnostics, and vaccines that tackle the threat of untreatable bacterial infections. Mr. Alderson's research focuses on the organization and finance of the health sector. Areas of specialization include global pharmaceutical markets, particularly antibiotics and other antimicrobials that can degrade in usefulness over time through resistance. Wow, we really do have the A-team with us today. Let's start out with you, Amanda, as our lead-off batter with the basics about AMR. In very basic terms, what is AMR and why has it become a global concern? How does antimicrobial resistance spread and how big is the problem? And who does AMR affect?
Well, those are several questions, so I'm going to start breaking those down. But essentially, antibiotic resistance, or AMR, is the process that happens when we use and overuse and misuse our antibiotics to the point where we're placing selective pressure on bacteria, and then those antibiotics stop being effective against those bacteria. And so then we're left without effective treatments. This is a problem that concerns everyone. We all rely upon antibiotics, whether it's for basic types of infections like strep throat or my children's ear infections, or more serious infections that can arise, particularly in medically complex patients, like patients receiving cancer chemotherapy or patients who have COVID-19 and get secondary infections. Really, antibiotics help to be the foundation of so much of our modern medicine, because just about any type of surgery can put you at risk for an infection, whether it's a hip or knee replacement or an organ transplant or a C-section. So as we've seen more and more resistance develop, we are seeing more and more infections that cannot be safely and effectively treated with the antibiotics that we currently have.
That's great. Thank you, Amanda. And Helen, I'll let you add on to that, but also, talk to us a little bit about, a large number of people may not have heard of AMR. In fact, a recent study that I've seen showed that only about half of Americans have even heard the word. But most people, we think, have heard of superbugs or MRSA or sepsis. How different is AMR from antibiotic resistance and some of these other terms?
Yeah, so great questions, Tom. And I think, as Amanda pointed out, this fact that bacteria become resistant over time is really what we're talking about. And no matter what we did, if we did nothing, we would always be encountering bacterial resistance to some extent. It's the use and overuse of antibiotics that makes it happen so much faster. And so despite our efforts, and some of us have been at this for 15 years or more, there still is a public perception problem. And so some people have heard of superbugs or MRSA. Those are antibiotic-resistant bacteria, and they have grown out of control largely through our overuse of antibiotics, and they can affect you and me. And I think that's one of the most important things, is this is a problem that affects everybody across the population. So for women, think about a simple urinary tract infection. We're seeing more and more otherwise healthy women in this middle-age group that I'm part of show up with urinary tract infections that don't respond to initial therapy. It's not until that lady comes back to the doctor once or maybe twice or winds up in an emergency room really sick that we do a test that tells us that that infection is caused by a bacteria that's resistant to every pill. So we have a group of people now, otherwise healthy people, who need an intravenous antibiotic to treat that bad infection that is really shouldn't be a problem at all. It should be treated with 3 days of a pill in a regular person. The other end of the spectrum is, as Amanda mentioned, are immunocompromised patients, people who've had organ transplants, the most vulnerable. The only way they get through that process is with the support of antibiotics, right? We have to give them antibiotics to support them through the surgery and then to keep them safe afterwards. So if we don't do something about this problem of resistance, it could put our ability to care for folks and to give them things like transplants or even to deliver babies at risk.
Wow. And Amanda, I'll throw it back to you just for a minute. What are the factors or drivers that are playing a role in why is this getting worse?
So, as Dr. Boucher said, every time we use an antibiotic, we are contributing to resistance. And so the overuse and misuse of antibiotics in human healthcare, in animals and agricultural settings, and in the environment is so very troubling. These high volumes of unnecessary or inappropriate antibiotic use really provides just tremendous fuel for the development of resistance. So the CDC has actually estimated that 30% of antibiotics prescribed in doctors' offices and emergency departments are completely unnecessary. And inside of our hospitals, CDC estimates anywhere from 20% to maybe as much as 50% of antibiotics prescribed in hospitals are unnecessary or inappropriate, meaning we gave someone the wrong antibiotic or for the wrong duration. And all of that misuse is what's really helping resistance to develop so much more quickly. I know obviously COVID-19 is really top of mind for all of us right now. And in the early months of the pandemic, we saw extremely high levels of antibiotic use in hospitals. And that may have fueled the development of new resistance threats that haven't even been identified yet.
Thanks for that. And Kevin, we're Americans, right? Why don't we just make more? Why don't we just make new antibiotics? I mean, that's what a lot of people would say, right? Why are there so few new antibiotics? And can we just develop new antibiotics that bacteria can't resist? Is it just about putting more money toward it?
Science certainly can address the problem, but we're having a difficulty giving the companies the right incentives to create these drugs. Think about a cancer drug. When a really novel, great new cancer drug comes on the market, it's used a lot, right? It's used for anybody who can possibly benefit from it. When an amazing new antibiotic comes to the market, we try to use it as little as possible. We put it behind glass and save it for a rainy day. That's a great response. We call that antibiotic stewardship. It's something we have to do to be careful with these drugs. But the result is that the companies can't make much money selling them. And so we have a fundamental mismatch between what the science makes possible, what doctors want, and what the market is willing to pay for.
Okay, and we'll get more into that. How do we fix that situation a little bit later in our conversation. Sandy, we've all read a lot about disparities of health outcomes among communities of color. What's happening with AMR? Are similar things happening with AMR, and distinctions and differences in care for communities of color? Is there a disproportionate burden here as well?
Yeah, Tom, that's a great question. I think what really we saw with COVID-19, there was an incredible disparity in terms of mortality for patients of color. In particular, Black patients were 2.3 times more likely to succumb to COVID-19. And I think for some of the reasons, we understand there's a lot of historical context in a lot of social determinants of health that really impact how patients receive care. So when we look at AMR, what are some of those factors? Well, it could be related to housing. It could be related to income and language barriers and access to healthcare. And so we are seeing disparities among patients of color as it relates to AMR. It really starts with physicians. It starts with providers, clinicians, and their practices, or our practices, in prescribing antibiotic therapy. And what are some of our biases as we prescribe medications as well. And for patients, it's important that we really support them so that they can advocate for themselves as they are in their doctor's offices or providers' offices and receiving medication therapy or receiving just information on what to do next if they have any issues. But I think there's a lot of literature that supports disparity. For instance, in MRSA, knowing that many patients who live in public housing or multi-generational homes, depending on their types of jobs and geographical locations, there's so much literature that supports the disparity amongst people of color and AMR.
Yeah, and hopefully we'll talk about some of the potential solutions, and perhaps a related question, Helen. Are there certain conditions? We talk about comorbidities, including pregnancy, perhaps. Given our audience, that can put people at a higher risk for AMR.
Yeah, well, so we know some about this, right? So AMR affects everybody across all kind of walks of life, but we know that people who are hospitalized for a long duration, who have a lot of medical complications and a lot of procedures, are at particular risk. People who need a lot of antibiotics, ironically, if you need a lot of antibiotics, you're at risk of developing resistance. So those are groups we know about. So think cancer patients, our transplant patients, the really vulnerable, the very, very young, little tiny premature babies, for example, are at particular risk. But then there are these groups, like we mentioned earlier, the women with urinary tract infections. Those are otherwise healthy folks. And they've become a sizable group of people who have resistant infections in our country. So we have to think about kind of the risk factors that seem obvious. And then there are others that we haven't really perfectly characterized yet.
Yeah, and follow up to that, we've talked a little bit about, the COVID and confusion and kind of speed to care or anticipation of care for COVID patients. Has COVID, helped in some way by shining a light on this issue? Talk a little bit about the intersection of COVID-19 and AMR, if you would.
Sure. Well, we're still learning about it. I think it's really important, right? We're 18 months into COVID, and it's definitely not over, sadly. We're seeing scary numbers in our country today. And we have seen, as Amanda mentioned earlier, that at the beginning, all of us, I'll include myself, overprescribed antibiotics in the worry about secondary bacterial infections. We've learned that about 10 to 15% of folks who come to the hospital with COVID develop a bacterial infection. And it's still unclear what proportion of those are due to resistant bacteria. We know that if you're an individual who's in the hospital for a long time with COVID, particularly in the ICU, you're more at risk of developing an infection due to resistant bacteria. We've seen some very nasty infections in those patients. And so it is the case that for some people, we are able to support them through the COVID, only to have them succumb to a resistant infection. So there is a huge intersection here. And I've seen cases and had phone calls about cases of patients, young patients included, who have survived through the COVID, but now have a resistant bacterial infection in their lung or in their abdomen that ends up taking their life. And that's a position that none of us want to be in, right? We are in infectious disease because we can cure infection. And so having nothing to offer that patient is beyond heartbreaking. And part of the reason, we're here to raise awareness and to talk about some of the potential solutions with Kevin and others.
Yeah, and follow-up question on that. We don't have a Tamiflu for COVID-19, right? We don't have a therapy, something to go and take. So you're kind of getting treated when it gets very, very serious. Can you speak to that, Helen, at all, and kind of what change that might make, and maybe Kevin weigh in on that as well?
Sure. Yeah. Well, so it's important. We do have a couple of therapies for COVID, right? So for people who are sick enough to come to the hospital, we have remdesivir, which is an antiviral that's given intravenously, and we have dexamethasone, a steroid. And the dexamethasone has been shown to be life-saving. But as you point out, Tom, that's for when people are sick enough to come to the hospital and really quite ill. The other medicines we have are the antibody therapies, and those can be given early in disease. They're kind of complicated to give because you have to give them intravenously, and you have to have a place where you can see a patient with COVID quickly, as soon as possible after the diagnosis, to give them this medicine. But these medicines are quite effective, and we shouldn't forget about them. And during this wave, I know there's a lot of effort being made to get those antibodies closer to the patients. As you point out, however, we have no pills. So we're way behind on an antiviral pill for COVID. There are a couple coming through clinical development now, but the scientific hurdle is quite high. And then the development hurdle is high. And I'm sure Kevin has more to say about that.
Kevin, you want to jump in just for a minute on that?
I'd say that the miracle pill against bacteria was penicillin in 1942. And we don't have the same thing like that for viruses or for COVID specifically. But that miracle pill for bacteria that did so much to expand human life spans and to prevent and treat and cure diseases, those are the things that are being destroyed by resistance. So this is a drug sector in which your best, most amazing invention ever has to be replicated every generation, or else you fall behind, which is different than everything else in drugs, in which the best heart disease medicine is still going to work just as well a decade from now or 100 years from now. But the best antiviral or antibacterial innovation, you have to go back and do it again, every generation or so.
Really, really interesting point. Thanks. Thank you both. Sandy, in New Jersey, what are you seeing in terms of AMR during the, before and during the COVID pandemic that we are still now, solidly within.
Yeah, I don't think it's unfamiliar just to what folks have said already in terms of prescribing and overprescribing in the beginning of this pandemic, just really being unsure of what we were dealing with. I think in the hospitals on the acute care side, and as we look at post-acute, we're still seeing patients who are having C. diff, who are aseptic with MRSA. We're still seeing complications of respiratory illness. And so as we really progress in New Jersey, we're looking at creating antibiograms and really focusing in on some top bacteria to really hone in on, and also looking at it from a regional perspective. We're working with our departments of health and with our 72 acute care hospitals to develop these antibiograms to help guide and lead best practice around prescribing and stewardship. And so I think that that's a trend that we'll start to see a little bit more, as these priorities are just really on the front burners and trying to reduce some of the tragic loss that we've seen throughout this pandemic.
Yeah, I can see, the collection of data and the leveraging of data could be very, very helpful for this situation going forward. Kevin, you talked a little bit before about the challenges of bringing new antibiotics to market. Is there anything more you wanted to add in there, like perhaps about, the payment structures and kind of the lack of interest by the venture capital community and others because the returns are so limited and uncertain?
I'll say two things. One is that whatever antibiotic we'll need in a decade, we need to start preclinical discovery work on that drug today. So, we have to predict which drugs will be lost because of resistance and start those research programs now if we want to have it 10 years from now. That's how long it takes. Then the second thing is that if a company brings a new antibiotic to market, sometimes they miss the timing. Maybe the drug they're trying to replace is not dead yet. Maybe Helen and many of the physicians and people doing stewardship work in hospitals, maybe they've done a great job in preserving the existing antibiotics for another 5 years. That's wonderful for public health. That's a great thing for the world. But it means that company has no sales for 5 years. And so Congress is actually looking at something called the Pasteur Act, named after Louis Pasteur. Someone was a genius putting that name on it, which would give companies a subscription, something like Netflix, so that the government would pay something for the antibiotic every year, even if they didn't need much or if we needed a lot. So we say it's like Netflix because you pay the same whether you watch nothing or whether you binge 24/7 on vacation. Either way, the payment, the monthly payment is the same. And this would get us past this hard difficulty of companies not knowing today what exactly is going to be the shape of the problem 10 years from now.
Yeah, it seems daunting, but help seems to be on the way. I think there's a recognition that the market can solve many things, but this is one of those things that the market can just not solve for the reasons you laid out. And Amanda, I know your organization IDSA has really been on the front lines in pushing for the reintroduction of the Pasteur Act. Talk a little bit more about federal policy efforts and the focus on policy as the key to helping solve this situation.
Absolutely. Well, I think as we've all been discussing and hearing, AMR is a really complex problem. And so the solution sort of by its very nature needs to be multifaceted. So I'll talk a little bit about what the government is doing and how that can be strengthened. And then about some of the brand new things like Pasteur that the government really needs to start doing. So we want to develop new antibiotics so that we can really reduce the impact of AMR on patients who get these infections. We also really want to do as much as we possibly can to prevent resistance and prevent infections in the first place. And the federal government does have some important initiatives underway that have made some important progress in the last few years. But it's really, I think, important to emphasize that what we're doing right now is not enough. And each of these were really intended to be first steps that we have to build upon. So, with regard to antibiotic development, federal agencies like the NIH and other federally funded initiatives like CARB-X that Kevin runs have been, doing a lot of important work, partnering with small companies to help support antibiotic research and development. But as Kevin has said, that's not really enough. We're able to develop some new antibiotics, not as many as we need. And then there's not really a market for these antibiotics because we try, as Kevin said, to use them in as limited a fashion as possible. So we've seen some small companies get federal support, bring a new antibiotic to market, only to then file for bankruptcy. And then, patients lose access to that new antibiotic. So clearly we've got some gaps here. On the other side, in terms of kind of more of your public health interventions, CDC supports really important surveillance and data collection to help us better understand this problem. But that needs to get a whole lot better because we really believe that we are undercounting the true burden of AMR. CDC also works with state and local health departments and healthcare providers and even other countries beyond the US to further scale up activities to support prevention of AMR and prevention of infections. And then within our healthcare facilities, Medicare now requires that hospitals have what we call antibiotic stewardship programs. And these are the programs that have been proven through piles and piles of research to be very effective at improving patient outcomes and decreasing inappropriate antibiotic use and decreasing antibiotic resistance. The problem is not only are there gaps with each of these programs, but every single one of them is underfunded, sorely underfunded. So our scientific researchers, our public health workers, our healthcare providers on the front lines really need more funding to do all of this vital work. And so every year as Congress and the administration work on the federal budget, we try and get more and more resources to help support this important work. And then Kevin mentioned the PASTEUR Act, and I think this is the new initiative that everyone who works on AMR is so incredibly excited about. It is a bipartisan bill, and yes, some things are still bipartisan here in DC, and this is one of those issues. And, as Kevin described, it would really fundamentally change the way that the federal government pays for the most critically needed new antibiotics. So we're paying for value rather than just paying for volume. And that helps provide that predictable return on investment we need for antibiotic development. And it takes away any kind of financial pressure to push overuse of these drugs. So we are really, really excited about this bill and think it's something that can really dramatically improve our situation with AMR.
That's great. Thanks, Amanda. Sandy, we know, very often innovation on many things happens first at a state level and then moves toward, other states adopting and perhaps federal adoption. What's happening from a policy perspective in New Jersey or any other state examples you might want to bring up, in terms of innovation and collaborative effort in the fight against AMR?
Yeah, I think one of the things I mentioned, our stewardship program started as this antibiogram work, and I think it's happening in many different states across the nation. Really the impetus to get hospitals together regionally and looking at whether there are hotspots around bacteria that they want to really hone in on. I think a lot of the work, it starts, at home. And so what are hospitals doing to educate their prescribers? And also we have to look at this from the curriculum perspective. Are we doing a good enough job in our nursing schools and our medical schools to talk about resistance, talking about alternatives as we are prescribing, talking about cultural and linguistic barriers, cultural, practices for families who may come from Latinx background who, don't see a problem with taking medication that's normally prescribed in the States, but if it's available back home, and really taking it just kind of as an as-needed basis and not having sought any medical care, really educating our patients, families, and clinicians alike, ensuring that there's access to those resources in languages that they can understand, making sure that we have medical appointments available for those who say, listen, I work all day, I have to pick up my kids, I don't have time to go to the doctors, and if I have a cough, I'm just going to take this antibiotic that I got back home, versus having, telemedicine appointments available for folks, again, having clinicians and providers who speak their own language, and really understanding how that really plays a huge role in terms of resistance. There's a lot of big picture things. I talked about social determinants and socioeconomic status. Housing is a huge concern where we can't fix that in a bubble. However, I think as we look at legislation and policy overall in managing chronic diseases and in managing some of the issues we see in AMR, we can do our part at a very local level, starting where we are, and then we're kind of moving up to our states as well.
That's great. Thanks, Sandy. And Helen, kind of zooming in on this issue, we know the majority of antibiotics are used or are prescribed outside of hospitals, some 80% or so. What actions could healthcare providers and individual hospitals be taking to help solve the problem?
Yeah, so great point. And I'm going to come back to something that Sandy said after this. So there's mounting data on hotspots of prescribing, if you will. So urgent care centers, retail clinics, for example, the CVS Minute Clinic, where a lot more antibiotics are prescribed for things like respiratory infections. And if you look at the difference between a hospital emergency room, a doctor's office, and an urgent care center, you see vastly different numbers. And it's hard to believe that the patients would be that different. So certainly some opportunities to make progress there. There are other places like the dermatologist's office. A huge amount of antibiotics are prescribed for skin conditions, and then the dentist office. And we know that dentists, we have good data, good studies that show that dentists prescribe vastly more antibiotics as preventative therapy than are recommended by current guidelines. So those are some areas of perhaps low-hanging fruit where we could make a difference. I also want to come back to something Sandy said. She was talking about developing local antibiograms, and that means figuring out what kind of resistance actually exists in my hospital or in my clinic or in my neighborhood. And it's important, I think, for all of us to know that in America in 2021, we still don't have the best view of resistance down to the local level. If you go to Europe, it's much more granular. So we still have work to do, as Amanda was saying, at the CDC and the local state department level to really local state health department, level, to understand what kind of resistance is active in my community so that we could enact the best measures to prevent that. So a lot of work to be done on many levels here, especially with prescribing, as you point out, Tom.
Thank you for that. And zooming in even more, I'll give this to you, Amanda. What are some ways, if people were motivated to get involved in policy, as individuals, what would you recommend?
Well, I'm so glad that you asked me that question, because we really do need for Congress to hear from a lot more people about this issue of antibiotic resistance so that they feel that political pressure to act to address it now. Senators and representatives, they are there to serve their constituents. So we all have a right to go and petition our government and let them know what's on our mind and what concerns us. I think there are a lot of different ways that people can get involved. Nonprofit organizations like Sepsis Alliance or IDSA or Healthy Women, I think are great kind of starting places for people to start getting involved. So, all of our organizations have contact information on our websites. I know that IDSA collects and shares stories of patients who've been impacted by antibiotic resistance. And when we bring those stories to Capitol Hill and share them with members of Congress and congressional staff, it really helps those policymakers understand how antibiotic resistance is impacting the real people that they represent. Social media is another great tool to get involved in advocacy. I think each of our organizations shares a lot of information on our social media accounts about antibiotic resistance. So people can use that information and share that with their friends, share it with their policymakers, help educate more people about this problem and help them get involved. And people should feel free to contact their members of Congress directly. Every congressional representative and senator has a website with their contact information on there. You can send an email that says, I'm concerned about antibiotic resistance and here's why I want to see the federal government do something. You don't need to be a policy expert. In fact, I think sometimes it's actually more compelling if you're not. I think members of Congress really like to hear from real people, not just from lobbyists like me. And I can tell you, as someone who once worked on Capitol Hill and my primary job was answering all that constituent mail, the representatives want to know what their constituents are writing in about, and it really does impact the work that they do and the policy positions that they take.
That's great. Yeah, I think, we often forget or we're intimidated because we think, we forget that these folks work for us and we pay their taxes and they really do want to hear from their constituents. So I think that's great advice. And I think, it's so true. It comes down to individuals. This is happening to real people. And whether you know somebody already who may have had, problems fighting and drug resistant infection, you will before too long. And so, I really want to talk about prevention a little bit. We've all heard a lot about the critical role of vaccinations to prevent infections from happening in the first place. What are some ways people can take action to protect themselves, their parents in many of our cases, and our children in many cases from antimicrobial resistance? And I'll start with Helen.
So I think there's a couple of really simple things people can do in the prevention department. So good old hand washing, right? We've seen during COVID, probably more than any other time in modern history, the value of good old hand hygiene and staying away from each other when we're sick, right? Stay home when you're sick, wash your hands a lot. I think the other thing people need to feel comfortable doing is asking their doctor if they really need that antibiotic, right? Instead of demanding an antibiotic, when one is recommended, ask, what is it for and do I really need it? Because that can be the difference between having a dreaded complication, including developing resistance, and doing okay. So I think those are a couple of very simple measures people can take. The other thing you should do is when you go to the hospital to have a procedure, make sure you go to a hospital that has good infection control measures, and that's all publicly reported on their website. So if you're going to have a surgery like a hip replacement, you can look on the website of the hospital and see how they do with infections. And you can protect your mom and dad, perhaps, and other relatives in that way.
Sandy, anything you'd like to add on to that in terms of prevention?
Yeah, no, I agree with Helen. And I think I would add really engaging with our patients and their families, because at the end of the day, when we tell a patient to go home and take this for 7 days and make sure you take it even if you feel better, there's really no way that we can confirm whether or not they do that. But if we ask them, I know maybe antibiotics is not something you're used to. What have you done in the past that helps you in integrating some of those holistic modalities that have some science to back it up as well? I think it's going to be important as we offer alternatives. And if the patient does not want to take antibiotics, what are some other therapies that we can encourage? How can we continue to educate patients, help them advocate for themselves? How can we continue to, as providers and as peers, keep each other accountable? If I work in an office and I know that patients will come in only, and this has happened, will only come in on Thursdays when I'm not there because I won't prescribe for them and another provider will, I have to keep my colleague accountable and say, hey, Z-Pak is not candy. We don't have to give it out to everyone who comes in with a cough. So let's talk about the evidence and best practice around antibiotic use. And having those conversations, not in silos, but from a very interdisciplinary approach, including our colleagues in the pharmacy field, including our colleagues in long-term care, because it's a continuum. So when folks are discharged into post-acute areas, we want to make sure that they're included on those conversations as well, even in home care and the like. So I think it's really important to have those conversations from a very interdisciplinary approach and also including patients and families in our decision-making as well.
Wow. Thanks, Sandy. We've covered a lot of turf in a relatively short period of time. So I'd like to close it out and hear from all of you on the question, what's the most important takeaway for women about why they should care about AMR, how it can affect themselves and their families, and what's that most important thing that they can do about it? And I'll start with Kevin.
Thank you. I think there's things that families can do and women leading families as consumers. For all the antibiotics we're using in people, we use more antibiotics in agriculture and livestock. And so things like what Chick-fil-A and McDonald's and others have done in switching to antibiotic-free chicken is a really big consumer move. And that changes companies who otherwise wouldn't listen to this discussion. Many decades ago, Dr. Wexman won a Nobel Prize for creating a new antibiotic, streptomycin. It was also the first antibiotic useful against tuberculosis, which still kills hundreds of thousands of people a year around the world. Last year, tens of thousands of pounds of streptomycin was sprayed on orange groves in Florida in order to avert a bacterial disease which is killing orange trees, a serious disease. But people may not realize that when you buy a glass of orange juice, there's not an antibiotic-free choice. So I think consumer choice, in addition to everything else we talked about, is powerful and effective.
Yeah, really, really interesting. I was just reading that many of the water filtration systems in the country are not sensitive enough to remove all the antibiotics that may be coming into the water system from farms and other use. So I think we can raise our voice, and you gave some really terrific examples. Helen, you want to take that one next?
Sure. I agree 100% with Kevin, and I would say that one of the biggest takeaways is that this is a problem that affects all of us. And I guarantee you that someone who's had an antibiotic-resistant infection, whether or not it's been talked about. And so I really plead with my patients to bring a voice to this. As Amanda said, we want to hear about patient stories. That's what's going to move the needle here. And if you know somebody, when you know somebody, tell someone about that, help them find their voice, because that's how we're going to make a change. It's not too late to make a change. And I don't want to end this on a negative note. There are a lot of things we can do to change this problem so that we can secure the healthcare that our families need and our kids are going to need, so that they can get that organ transplant and surgery when they get older. So take part, be a part of the change. Thanks.
That's great, and thanks for turning it to an upbeat notion. There's hope. We can fix this. And Amanda, you made a great case for telling your story. If you have a story, do you want to add on to that?
Sure. As a mom, I really, really care about this issue, and I'm deeply emotionally invested because I want the healthcare system to be able to work for my kids when they get older, when they need some type of care. I want antibiotics to be available for them. And I don't want to live in fear of them getting an antibiotic-resistant infection that will be untreatable. And I think, women are natural advocates. We advocate for our families. We are often the ones that make healthcare decisions for our families. We have, I think, a tremendous amount of power to do enormous change by sharing our story, by educating our colleagues and friends and our networks, and bringing our voices to policymakers and letting them know that we care about this issue every bit as much as we care about issues from childhood obesity to the opioid epidemic, you name it. And I think this is absolutely something where we have a tremendous opportunity to do a lot of good.
Thank you so much for that. And before I go to you, Sandy, I want to kind of double back a little bit to, the work Kevin at Carbex is doing on the innovation side. So kind of, to the point of we're all in this together, nothing could be more true. And, it's individuals, families, public health institutions, industry, government, all needing to work together. And, just talk a little bit more specifically about the work of Carbex and some of those initiatives that we're seeing and hoping to advance more fully to help with solving this issue.
Well, the short version is that there's amazing science out there. There's tremendous things that are coming out of universities and research institutes. There's a lot of great new antibiotics out there. And we've seen with COVID that if you put enough money at something, you do get interesting solutions with vaccines and eventually therapeutics. But I want to stress that everything that people have talked about, stewardship, from Sandy and all the things that Dr. Boucher has talked about as well, these are important because they slow down the rate of resistance. And we can't just keep throwing new drugs into the fire. We need to turn down the rate of resistance. And so I really believe we do both. We do, everything. Be very careful with them and also bring new things to market. I'll say one more thing. For families, I think Helen, Dr. Boucher mentioned that please talk to your doctor and make sure that you really need the antibiotic. Don't beg your doctor for antibiotic. I think many people have had the attitude that an antibiotic is only an upside. It only could cure. It's not going to hurt your child with the earache or whatnot. But we know that antibiotic not only can hurt society by promoting resistance, but it can really disrupt the microbiome of your child or any person who's taking it. So it's not something that has no downside. You need to think about being careful with these and have the appropriate conversation with your physician.
I think that's a great point, Kevin, you make about that, this is not an only good. And I think there's a real opportunity for education around that this is not just good for you, it can be bad for you as well. And all of a sudden a balance comes into the equation of begging for that antibiotic for yourself or your child. Sandy, I'll give you the closing opportunity to talk about most important takeaway for women and families about what they can do and what kind of a difference they can make.
Oh goodness, no pressure at all. But I think I just agree with my colleagues on here. I strongly just want to encourage women to play their role as influencers, which they are already. So many women are matriarchs of the family. We are going to the appointments with our children. We're scheduling appointments for our husbands and our fathers and our brother-in-laws and whoever. And so I think as we have that level of influence, having those conversations and doing things like this with healthy women to really encourage those conversations at home, at the dinner table, and just kind of sharing knowledge on something that we didn't know before and continuing to influence through social media, sharing this presentation as well on your different social media pages and women's groups and churches. I think that we need to really engage in more community conversations. And so wherever the people are and patients are, let's continue this work and this type of advocacy so we can continue to really just do better as it relates to AMR. So thank you so much for this opportunity.
Thanks, Sandy. Thanks, Sandy. You nailed it. And I feel better informed and more optimistic than I did an hour ago. So thank you all. And on behalf of Healthy Women, I want to thank our panel. And we thank you for joining us today. We truly appreciate you being here and hope you feel more informed, as do I. We invite you to visit healthywomen.org for additional resources on AMR, including links to the organizations and initiatives mentioned during this presentation. And thank you to our incredible panel, and Helen Boucher, Sandy Kao, Amanda Jessic, and Kevin Alderson. And finally, I want to thank Pfizer for their support of this webinar. Thank you again. Have a wonderful day.